I'm going to talk about intrapartum fetal surveillance, and also we're going to talk a little bit about antepartum fetal surveillance. Oops, that didn't work. Sorry. What is fetal surveillance? What does it mean? Why do we do it? So basically, when we're talking about fetal surveillance, this is what we're saying when we're talking about fetal monitoring. In the United States, people are monitored throughout labor. Um, we are a litigious society. The research actually doesn't always support it, but that's kind of a whole nother rabbit hole we can go down. But the standard of care in the United States is that when people are in labor, they are on continuous fetal monitoring. Some people, if they use a midwife or they deliver at more of a birth center, it may be intermittent where they take them off and on the monitor. But at any of the major hospitals where our clinicals are, you will see once someone's in labor, they will be on fetal surveillance. So what the heck does that mean? Basically, we use a machine to record fetal heart rate and to record the contraction pattern. And the whole thing we're trying to find out is our baby oxygenated? Is the baby getting oxygen? Um, we know if the baby has a heart rate that's within the normal range, 110 to 160, that can be a good sign that the baby is not hypoxic, okay, or acidotic. Those are the two things we're looking at. So if you look on this slide, there's two ways we can approach intrapartum fetal monitoring or antepartum. So for example, when you go every prenatal visit you go in, once you're past it, or every single one, they'll either use an ultrasound if it's too early, but once you're big enough, they'll use a Doppler and they will do what's called auscultation. And that's considered intermittent auscultation. They use a daptone, and we saw that in the lab to listen to the fetal heart rate. And it just gives us one number. So it's actually not a heart rate, it's a heart tone. It gives us a fetal heart tone, and we want it to be between 110 and 120. So for example, I have a patient come in for her 30-week prenatal appointment. Go ahead and put on the daptone, and it sounds like 90. That would be concerning. What would be my next step? My next step would be to throw her on a fetal monitor, because the fetal monitor is what then it's an ultrasound, it's that round disc, and it's actually an ultrasound is what it does. It doesn't give us an ultrasound picture, but what it does is it gives us a tracing of the fetal heart rate, and that tracing gives us a whole lot of information. The pattern that the fetal heart rate makes in relation to contractions, whether mom is contracting or not, can tell us a whole lot about baby's oxygenation. So the whole reason why we use fetal surveillance is to see, is the baby tolerating labor? And when we do it during labor, intrapartumly, is the baby tolerating pregnancy when we do it during antepartum visits? However, that's called a non-stress test when it's done during an antepartum prenatal appointment. It's called fetal monitoring when it's done during labor because it's just continuous fetal monitoring. However, we don't send, if someone has to be on continuous fetal monitoring, they have to be admitted to a labor and delivery unit. Are there times a patient comes in at 30 weeks, they put them on the fetal monitor, don't love it, so they go ahead and admit them and keep them on for a couple days to watch it? Yes, because remember, we're always trying to decide, let the baby cook, go ahead and deliver. Let the baby cook, go ahead and deliver. Let those lungs get some more of that surfactant, or go ahead and deliver. So the way this happens is all moms at every prenatal appointment will have a daptone to listen to the fetal heart tone. If it's concerning, they will then go on to a fetal heart rate monitor to do a non-stress test. It's called a non-stress test because back in the day, they actually used to give the mom a little bit of Pitocin to try to get her to contract and see how the baby would react to the contractions. That was called a contraction stress test. I've never seen that done in my 20 years of practice because guess what would happen? Some of those moms would actually go into labor, lo and behold. So really a contraction stress test is no longer used. It's now called a non-stress test. And it's not really a test. The mom just lays her, has a fetal monitor on her, and we look at the pattern that the fetal heart rate makes. And I'll go into a little bit more detail as to what we're looking for as we go through these slides. But basically, your takeaways: fetal surveillance, it's done intrapartumly during labor to see how a baby is tolerated in labor. It's done antepartumly at prenatal appointments. First fetal surveillance, it's used as a daptone to see what the fetal heart tone is, if that's not accurate, or if it's concerning in any way, then the mom is put on a fetal monitor. And when it's done at a prenatal appointment like that, it's called a non-stress test because it's done for a limited period of time. It's done between 20 and 40 minutes. Um, Therefore, if after 40 minutes we're still not getting the information we want, that mom now needs to be admitted to the hospital for continuous fetal monitoring. Same machine, just different terminology in whether they're at an appointment or in the hospital. So the whole point of doing this is fetal oxygenation. It's one of the only ways we can check fetal well-being. I don't know why I have that little bubble there, but we know that in order for a baby to be oxygenated, there needs to be normal blood flow through the placenta. There needs to be normal exchange. The umbilical cord vessels need to be patent, not clotted. There needs to be normal fetal circulation. So all of, basically, if fetal oxygenation looks okay, all of these other things will show us. We can be reassured that these other things are working as well. And so we can't take a pulse ox, right? We don't do that now. There is some research out there during labor where they're able to look at that, but I've never actually worked anywhere that has done that. So we can't do a fetal pulse ox. So instead, we try to look for other indicators that show us that the baby is oxygenated. And we look at that by looking at the pattern of the fetal heart rate. And then we can know then that the baby is doing okay, or hopefully be reassured, right? Nothing is 100%, because have I had great looking fetal monitoring strips and crappy babies? Heck yeah, I have. And I've had crappy ass looking strips where we crash them on and the baby comes out perfect. So this is not an exact science. There's actually a lot of controversy behind it because many people feel like it straps people to the beds, and we know a woman needs to move around in labor. However, they have come up with fetal monitoring that all the hospitals have where they can walk around with it. They're able to get in the shower with it. It's remote, so the doctors can watch it from their house. The nurses can watch it from their desk. And really, it seems like that's amazing. We should be able to catch all problems. But you know what? It's a little insidious. Unfortunately, that isn't exactly what happens. But this is the standard of care in the United States is continuous fetal heart rate monitoring for the most part. So basically, we know that for a fetal heart rate to be regulated and in the appropriate range, you need to have the autonomic nervous system, baroreceptors, chemoreceptors, adrenal glands, central nervous system all working correctly. So the takeaway, you don't need to memorize that. The takeaway is if all these mechanisms are working correctly, that's a good sign. If they're not, we will have let me see, let me read my sentence exactly. All these mechanisms must work in an oxygenated, uncompromised fetus. So that's a good sign. This baby is uncompromised. If this baby is compromised from any of these areas, we're going to see it in the fetal heart rate. So it's just giving us a picture and an idea of what might be going on with baby. It is not an exact science. It is not always 100% accurate. There are definitely some judgment calls that need to be made. But what has happened is we've standardized terminology when we're looking at fetal heart rates. This is when we talk about professional organizations. So ACOG, which is the American College of Obstetrics and Gynecology, and A1, which is Association of Women's Obstetrics and Neonatal Nurses, they got together and standardized the terminology so that when I'm talking to a doctor, if I say moderate variability, he knows what I'm talking about. Or if I say it's a reassuring fetal heart rate, he knows what I'm talking about. And so that's where we've used standardized terminology to make sure we're all using the same words and meaning the same things. So what can affect oxygenation? So let's think about that. What could affect fetal oxygenation? I don't know, labor, right? That would be the first thing when we're looking at fetal oxygenation during labor. How is baby tolerating labor? Contractions, as I talked about before, babies are holding their breath with every contraction. And as I clarified for Courtney's question, that no, they're not physically holding their breath. It's a I don't know what's the right word. What do you call that? It's not exactly what's happening. What's happening though is with every contraction, it's a metaphor, I guess. Every contraction is squeezing and clamping off those spiral arteries, which is what causes the transportation of oxygen to and from mom and baby. We know baby has reserves though in the placental blood, right? So the baby can tolerate quite a bit of breath holding. I just said that in quotes. I did air quotes if you could watch me right now. However, eventually those reserves wear out and a baby may not be tolerating labor as much. So what kinds of things might affect Oxygenation. I don't know. Low blood pressure in mom. If the placenta is not being perfused, if the mom, is hyperstimulated, meaning hyperstimulated, lots of contractions greater than every 2 to 3 minutes, 1 to 2 minutes, that's too much. Baby will do okay for a little bit and then baby will plummet. And you'll see that in the fetal heart rate strips. So anything that might interrupt umbilical blood flow. The baby's leaning on the umbilical cord and cutting off the umbilical cord. That's when we start to see variable decelerations, which we'll talk about. What's the best way to get baby off that umbilical cord? Flip that mom over, put her on hands and knees, change her position, try to get that baby in a different position. So remember, fetal heart rate monitoring is one way of doing fetal surveillance to check during labor how baby is tolerating labor, and antepartumly how baby is tolerating pregnancy. Maybe we have a preeclamptic mom, which we'll learn about next week, and she's having rising blood pressures, and that those blood pressures are starting to affect the flow to the placenta, and now we're starting to see it in baby. So certain moms, depending on what they may have going on with them, will actually have to just have non-stress tests. I never had a non-stress test during any of my babies. I had all my babies before I was 35. We know with advanced maternal age, placentas can get a little old and so or not work as well. So those moms will have non-stress tests. If you have any kind of underlying condition like diabetes, preeclampsia, there's all different kinds of things. All different kinds of problems that can happen. Maybe you have some sort of weird underlying problem overall. Those moms will automatically get non-stress tests in the doctor's office starting typically around 32 weeks, 34 weeks, and they usually go twice a week. And basically, a reassuring non-stress test shows us that the baby is not compromised. So again, a non-stress test is just continuous fetal monitoring done for a short period of time. Okay, so continuous fetal monitoring during the intrapartum period, during the antepartum period, and prenatally, it's done for 20 to 40 minutes to see if it's reassuring. Okay, it's exact same machine, heart rate, Toko looking at the contractions. We'll talk about that. So why might we see some problems during the intrapartum period? Hyperstimulation with contractions, hypotension. Maybe the baby has an undiagnosed cardiac anomaly, and now that we're stressing the baby out with labor, the baby, for whatever reason, can't tolerate it. What if there's a placental problem? It's an old placenta. There are those calcifications. The mom is post-dates. Remember, term is 37 to 40 weeks. This mom is post-dates. Abruption. The mom came in after a car accident and she's starting, remember, abruption is when you have the pulling away of the placenta from the abdominal wall and it causes abdominal pain, a board-like abdomen because the blood is pooling and it causes such uterine irritability it starts to get really firm, and sometimes no bleeding or dark red bleeding. What do you think those babies' fetal heart rates are going to look like? They're going to plummet. Previa, that's when you have that bright red painless bleeding. It doesn't hurt at all. So abruption is abrupt. It hurts, abrupt. Previa doesn't hurt. It's just the placenta is growing over the cervix a little bit and there's some bright red bleeding that's happening. Depending on how much the previa is over the cervix, could depend on how much blood is being lost and is it affecting baby. So here we go. This is what we call electronic fetal monitoring. It gives us data about the fetus that is more than just a daptone, right? The daptone gives us one heartbeat in time, one tone, where fetal heart rate provides us with a pattern. It's stored electronically because it's often used in court cases. Can reduce mobility, but we're seeing newer cases are helping mom. Newer models are much lighter and smaller and moms can walk around. So what does an external fetal monitor look like? So you'll see these in the doctor's office, okay, and you'll see them next to every bed in labor and delivery because in a doctor's office, it's used for non-stress tests. In the labor and delivery unit, it's used for continuous fetal monitoring, okay? Same machine, same exact thing, two different words, okay? There's an ultrasound transducer that measures the heart rate. It moves around on the mom's belly. It's secured by straps. You have to go in and adjust often. But this is allowing for remote surveillance. So we can see it at the desk. The doctors can now bring them up on their phones and things like that. It's outside of the body, right? It's not going to be as accurate as an internal monitor, which we'll talk about in a little bit. A toco then is used to measure the contractions because remember, we're trying to look at the fetal heart rate in relation to the contractions because we're stressing this baby out with labor and we need to know maybe this baby's been great throughout the whole pregnancy. Now you add labor to it and the baby's like, crap, I had an undiagnosed cardiac anomaly and I can't handle this crap. And you'll see it in the fetal heart rate. So we got to be able to see how does a baby react to contractions. So it's the pattern the fetal heart rate makes over time in relationship to the contractions that the mom is having. Or maybe she's not having any contractions. And we need to know that too. If you're giving Pitocin to a mom, I sure as heck want to see how often she's contracting, right? We can't up Pitocin, titrate it up if we can't see her contractions. That would be dangerous because we could hyperstim her. We could cause her uterus to rupture. We could give her too much. We could tank that baby out because the baby can't ever catch her breath. So we have to be able to see how often mom is contracting. We have to in order to either induce or augment labor with Pitocin. Remember though, with an external monitor, you cannot truly tell how strong mom is contracting. If it's in a really good spot, it'll make a nice little hill. But that's really just how it's picking up. The only way to tell how mama strong is contracting is to ask her or with an internal monitor, and I'll talk about that in a little bit. You can also, we always palpate the abdomen because you always hands on patient. You never rely on monitors, always hands on patient. You put your hands on the patient's belly every single shift and you hold it there for a couple minutes so you can feel a contraction and then you can feel the belly get soft. During a contraction, the belly's going to feel like your forehead. So everybody hit their forehead right now. Press on it with your finger. That's how hard the belly gets during a contraction. When it's not contracted, it feels like your cheek. Okay. If it's a mild contraction, it feels more like your nose. Severe is going to feel more like your forehead. You need to hands on patient. If you are in a lawsuit and you never touch that patient, you can't tell that it was actually picking up contractions or not and that they were accurate. So always remember that. Here's a picture of a nurse and a mom with a bad perm from like the 1980, 85 maybe. However, this is the fetal ultrasound. So she's moving that around. That one's always on the bottom and she's trying to pick up the heartbeat. You have to continually move it around. For the moms that are larger, this can be difficult. It can be hard to pick up a fetal heart rate. Then the toco looks just like this, but it's a little different. It has a button on the inside and it measures it measures the pressure change of the contractions, and that's going to be the one upper on the belly. And again, this is the big monitor next to the bed, but there's now these little portable monitors like this that they can pop into and the mom can walk around and be waterproof and things like that. So why would we go to internal fetal monitoring? Is this standard protocol? Absolutely not. I never had internal fetal monitoring, and I even had a vaginal delivery after a C-section. I was at increased risk for uterine rupture. However, my external fetal monitoring, which is the picture we just saw, were picking up my contractions and the fetal heart rate just fine, so I didn't need internal monitoring. Why would we use internal monitoring? And do you have to always use both together? No, absolutely not. Internal monitoring would only be used during labor. You're never going to use internal monitoring during a non-stress test. Non-stress test is what's done in the doctor's office with external fetal monitors for 20 to 40 minutes, okay? Maybe you extend it an hour at the most. Internal fetal monitoring is what could be done in labor. It gives us the same picture that we're going to look at, but why would we do it? We do, and it hooks up to the same machine. It's just a different monitor, and I'll show you that. It's a different piece. Why you might use a fetal scalp electrode? For whatever reason, you cannot pick up the fetal heartbeat anymore. The baby has turned in a position, the mom is, fluffier, and you cannot get it. And she has Pitocin going, and she's in labor. Do you just hope the baby's okay? No. Do you rush her back to a C-section? Well, heck no. You don't want to cut someone if you don't need to. We know that there's a lot greater risk anytime you go into surgery, and we'll talk about C-section next week. So what do? You put in a fetal scalp electrode. So nurses can do this if they're trained in it, as well as physicians. Obviously, the physicians can. But here's the thing. The mom's bag of water has to already be ruptured, right? If it's not, sometimes they'll actually rupture it with the fetal scalp electrode because there's a tiny little needle at the end that actually nicks into the fetal scalp and gives you the accurate fetal heart rate. Okay. She also has to be dilated at least 2 centimeters because the doctor or nurse has to be able to get it through the cervix to the head of the baby. So the baby also has to be head down, right? You're not going to get a fetal heart rate on a butt, that's for sure. So the baby has to be head down. You have to be able to get in there, and the bag of water needs to be ruptured. What might this induce? right? This might introduce bacteria. Anytime you start going into internal fetal monitoring, moms are now at risk for chorio, right? Even though we follow sterile procedure, is the vagina sterile? Heck no. So even though the piece is sterile, as it's going through the vagina, it's picking up bacteria. So these moms, once you have internal fetal monitoring, you're not getting out of bed. They cannot walk around with these. Um, it's not great. It's not ideal. It's kind of sometimes the first few steps that leads to a C-section, but you hope it will help to avoid a C-section and it will give you reassurance. If you put in a fetal scalp electrode and that heartbeat says 20, 40, 20, you're rushing back and you're cutting that mom as soon as possible because we know there's only 20 minutes of reserves and that baby has maybe already used a bunch of their reserves. But hopefully, more often than not, we put in the fetal scalp electrode and we all take a big sigh of relief because we're like, and we see 160, 150, yay, perfect. For whatever reason, that baby was just being a stinker and we couldn't get it. Why would you use an intrauterine pressure catheter? Well, basically, two kinds of IUPCs can be used to measure uterine activity. I don't know why it says two kinds. I only know of one kind of intrauterine pressure catheter. I'm sorry, I think I messed that up. So an IUPC is basically like a straw that's inserted into the mom through the cervix into the uterus. So again, must be dilated at least till 2, must have bag of water broken, and it lays between the head of the baby and the side of the uterus. So every time mom contracts, we can actually see how strong in millimeters of mercury the uterus is contracting. And I'm not going to go into what the numbers need to be, but I want to tell you why you would do this. You're giving PIT to a mom. You've reached the max you can give. She's contracting every 2 to 3 minutes and isn't making any change. Can you go up in that pit? No, you cannot, because that mom might be contracting so strong she could rupture her uterus. The doctor may put in IUPC, so then you can see, oh my gosh, she is contracting every 2 to 3 minutes, but it's these tiny little blips of contractions. She's not contracting strong. Let's tweak her medication. So it's really used if Pitocin isn't working and you don't feel like you can safely increase it based on what the external monitor is showing you. Also, interestingly enough, remember we talk about meconium, how some babies in labor poop because they're stressed out. Because the IUPC is a straw, it actually has another port to it that you can hook up normal saline. And sometimes doctors will flow normal saline into the uterus. You have to follow a certain protocol because you don't want to overdistend the uterus or anything like that. That could cause an abruption. It could cause the placental to shear, so you always have to be very careful. But that will thin out the meconium, so hopefully it's not so sticky if the baby aspirates it at birth. Sometimes it's used for thick meconium. It also might be used for a baby that's having a lot of variables. Remember I said, we actually haven't gotten to it yet, but I think I mentioned it. Variable decelerations are when the heartbeat drops down and comes back up, and it's caused by cord compression. So maybe this mom's been ruptured a while, doesn't have as much amniotic fluid, or has low amniotic fluid to start for whatever reason. And so fluid will help to cushion that cord. So try to put a little more fluid in there to help cushion that cord so the cord isn't being compressed as much. And hopefully we do both of these things to try to avoid a C-section. Both of these things to try to keep mom safely laboring and be assured that the baby is tolerating labor. However, these are not standard protocol. External fetal monitoring is the standard protocol. They would never be used antenatally or prenatally at an appointment. Same thing, antenatally and prenatally are interchangeable words. However, they are used during labor at times when external fetal monitoring is not giving us the information we need. So here's pictures of it. So I did an arrow here. This is that IUPC. And see, it actually is, it's the same machine. This is the exact same monitor. We just switch out what we're putting in. So instead of the 2 discs on the belly, we have these internal things. Again, you could have a external ultrasound and an IUPC, or you could have a fetal scalp electrode and an external TOCO. So TOCO is what we call what picks up the contractions, a TOCO transducer. The ultrasound is what picks up the fetal heart rate. Fetal scalp electrode, see there's this tiny little corkscrew needle and it screws right into the head there. And this would be contraindicated. What moms would we never use an FSC in? Let's think. Absolutely 100% contraindicated HIV positive. hepatitis B positive. I once had a doctor going to put a FSC in and the mom was Hep B positive. And I said, you know her hepatitis status, right? And he looked at me and went, oh shit, and was so glad he didn't do it. So anything that you don't want to introduce blood into the baby like that. So absolutely contraindicated in a mom like that. So this is the IUPC. So see how there's a straw here? They can actually go ahead and there's like a thing here that they can put fluid, and then the fluid would like go into the uterus and it just drips out. And as a nurse, you have to check that the same amount of fluid coming out is equal to what's going in. There's a whole standard protocol that we're not going to get into, but just FYI. And that might either thin the meconium that's floating around in there or cushion the cord. So that's internal fetal monitoring. So now we're getting the meat of all of it. Why do we even do this? Why do we use fetal heart rate monitoring? Why do we do this? What's the facts? What are the deals? This is something that I'm certified in. I believe Colleen is as well. There is a lot of nuances and a lot of in-depth information that we're not going to get into. You need to just know the basics of fetal monitoring. If you become a labor and delivery nurse or an antepartum nurse, you will have to know this in a lot more detail. But for right now, for what is expected of a baccalaureate program is for you to know the basics. So here they are. What's the basics? First thing we're going to look at, we're looking at the fetal heart rate on a piece of paper. What is the rate? What is the rate? We determine that. We usually round it to fives, like 110 to 115, 115 to 120, 130 to 135, and we look over 5 minutes, and you look in between contractions. You never get the rate during a contraction. So you look in between contractions, you add it up to 5 minutes, and you see what is the rate. It should be between 110 and 160. Bradycardia is less than 110, tachycardia is greater than 160. Do you guys remember what I said is one of the biggest indications or causes of tachycardia in a fetus? Maternal fever from maternal infection, okay? Really, really thing you see a lot and really important to understand because we worry about those babies being born septic. Another thing we look at is not just what the rate of the fetal heart rate is, but the variability. And I want you to try to understand this. If I were to just get up really quick, run upstairs, I hear my son screaming, I run upstairs, Oh, he's fine, he slept. Okay, so now I walk back down. What are you going to see? Is my heart rate going to be 80, 80, 80, 80, 80? No, it's going to go 80, 80, 90, 90, 90, 110. Oh, okay, 80, 80, 80, 80. It's going to change based on the demands and the needs of my body. So all of a sudden my flight or flight popped in, it went up, I was running, I needed more, more oxygen, my heartbeat needed to beat a little bit faster. So variability is just as important as rate. We want to see that this baby is able to adjust to fetal movement, okay? So we want to see accelerations in the fetal heart rate when the baby's moving. How the heck do we know the baby's moving? Well, the mom can tell us, but also we assume if the heart rate has accelerations, there's fetal movement. We can make that assumption. We used to have the mom mark it, but that is sort of old school. She would have this little thing she would hit and it would put a little like a little arrow whenever the baby moved, and you'd want to make sure the arrow matched the acceleration. And really research showed that if a baby's having accelerations, guess what? They're moving. So when might you see decreased variability? Absent is like if someone took a pencil and drew a line on a, oh my gosh, I can't even think of the word. The measuring stick. Oh my gosh, a ruler. If you took a ruler and you drew a pencil and drew a straight line, that's what absent variability looks like. That is never a good sign. That means that heart is barely able to just keep up beating. It can't fluctuate for anything. So absent variability is an ominous sign. Okay, minimal variability. So moderate, which is what we like to see, moderate, that's good, 6 to 25 beats per minute. So in a minute, you should see it go up and down. So 110 up to 135 down to 120. Now we could go up to 180. That's good. That's fine as long as it comes back down. Tachycardia is a sustained fetal heart rate for greater than 5 minutes above 160. Same with bradycardia. Sustained for greater than 5 minutes. It's not what's part of that variability. Marked is it's like up and down and up and down. And really, you don't usually crash C-section for someone that. You just watch it. Sometimes different medications, sometimes, I don't know, it's weird. I always feel like whenever I have marked variability, the doctors are like, I don't know, keep watching it. So absent is not a great sign. Have I ever seen absent variability, crashed a baby, and had a pink screaming baby come out? Yeah, what the heck? This is not an exact science. But more often than not, absent variability is going to be pushing mom to a C-section, okay? When you crash a mom is when it drops down to bradycardia and never comes back up. When you're at 80 and it's been a minute, you've switched positions, you've not done all your uterine resuscitation, which I'm going to teach you, and it's not coming up and not coming up, that's when you're crashing. You don't crash for absent, but you may move quickly to a C-section. However, what happens when I'm sleeping? If I'm not dreaming and I'm just sleeping, my heartbeat's going to be real, just slow and steady. Or what if I take a Vicodin because I've had surgery and I needed to take a Vicodin? Guess what? I'm going to be chill and slow and steady. So if a baby is having minimal variability, you're not going to just go ahead and like crash or go back to a C-section. You're going to wait and see. Is a heart rate within a normal rate? Okay. Are there decelerations, which we'll talk about? Nope. Bet baby's sleeping. Babies have 20 to 40-minute sleep cycles. Or did we give the mom a narcotic? Is the mom on magnesium sulfate? Remember, moms can be put on magnesium sulfate for two different reasons. A, you're anticipating a preterm labor and it decreases issues in the brain. Or B, it's used to treat preeclampsia. It's a relaxant. So try giving someone magnesium to relax everything and then at the same time giving them Pitocin to make their uterus contract. That is a challenging labor, but often it works. But you're going to see a sleepy baby with magnesium too. So rate and variability, two things we look at when we look at fetal heart rate. So here we go. Here's absent. It's like I took a ruler and I drew a pencil. I once had to call a doctor. This was before they could remotely look at it. And the other doctor standing next to me said, you tell him that you could take a ruler and draw it straight across. And as soon as I said that, he said, yep, I'm coming in, get ready for a C-section. Again, we didn't crash it because the heart rate was okay, but we did a C-section within 20 minutes because, again, we worry about those reserves. Because what if that baby hits the reserves and then it drops? Moderate, this is good. It's all over the place. This is what we like. Nice fetal heart rate. When you look at a strip, from one line to a next is a minute, okay? And then it's, you have to look at the sides, but it's typically either 10 beats difference or 5, okay? Depending on what kind of paper you're looking at. Minimal, it's still there, but it's less than 5. Moderate is at 6 to 25, but it's less than 6, so it's at 5, and you're like, oh, maybe baby's just sleeping. Market is like, who knows? Baby's like freaking out for a little bit. If it continues, they'll go ahead and do a C-section because they're like, I don't know what's going on, but I feel like usually it just corrects itself. So again, this isn't an exact science. So accelerations are good. Like if I were running a race and you saw my heartbeat go up, that's what we want to see. If I went to run a race and my heartbeat isn't going to compensate, guess what? I'm going to pass out because if my heartbeat doesn't compensate, it's not getting my oxygen. The blood isn't pumping fast enough to get the oxygen to everything that needs it, right? So we need accelerations. That's reassuring. So here's where it gets a little confusing. When someone is in labor and they're on continuous fetal monitoring, we call it reassuring or non-reassuring. And I didn't even put the slide in here, but you may see category 1, 2, or 3. Category 1 is like, yay, we like it. That's some of that terminology. If I were to call a doctor, hey, I have a category 1 tracing, or hey, I have a category 3 tracing. So 3 is you got to start thinking about a C-section. It's minimal variability. It's, there's all different criteria for it. But we talk about reassuring or non-reassuring. Accelerations are reassuring. Oh, good. The baby's heart is able to accelerate. That's a good sign that all those things we looked at in those first few slides are working correctly. When someone comes in for a non-stress test, so remember that's antenatally, prenatally, maybe you're 38 years old, so you're at increased risk for complications, so it's 32 weeks, we're going to start your non-stress tests. What we want to see are accelerations. And so instead of using reassuring and non-reassuring, we say reactive and non-reactive. Reactive, the baby's reacting. So remember, if there's accelerations, you're reacting. You accelerate, you react. If you're going to be hit by a car, you accelerate your car, right? So that's, hopefully, or I guess you stop, but we'll just think of it as accelerate. That's called reactive. So the criteria is for a non-stress to be reactive is you see 2 accelerations in 20 minutes. What does that mean? It means that you've determined the baseline to be 130 to 135. You need to you take the top number, 135, 15 beats above 135, so 135 to 150. you need to have at least twice in 20 minutes that heartbeat hits 150, stays there for 15 seconds, and then comes back down. That's called reactive. So you guys need to memorize this. You need to know the definition for a reactive non-stress test. Okay, again, not internal monitors. Those only would be used for continuous fetal monitoring during labor. This is for antenatally or prenatally. Okay, a reactive non-stress test. It used to be contraction stress test, and even in the office, they would start giving you a little Pitocin. Well, that is super dangerous. That is no longer done, but sometimes in questions or books, you'll see it because sometimes it takes questions and books time to catch up with current practice, even though I've never seen it in 20 years. But non-stress test, because we're not stressing the mom out, we're just having her lay there and we're looking at the contractions and we're looking at the fetal heart rate. And what I want to see is 2 accelerations in 20 minutes. That is what's called a reactive non-stress test. And then if it's reactive, you take mom off. That means it's reassuring. Even though we use the word reactive, it's reassuring, right? It was reactive. Mom, usually you do NSTs twice a week. So then she'll come back in a couple days, and then we can be rest assured the baby will be okay for the next couple days. Typically, they say a reactive non-stress test gives you the reassurance of fetal well-being for the next 5 to 7 days. Well, what if the mom abrupts? Heck no, there's no way to tell that, right? But if we're looking at sort of long-term complications like diabetes, preeclampsia, old placenta, advanced maternal age, it's reassuring for the next 5 to 7 days. So that's why typically doctors will do it like Monday, Thursday, Tuesday, Friday, so that you get through that weekend and then you come back and you're reassured. So they're watching this mom very closely to make the determination, let the baby cook or go ahead and deliver. Let the baby cook or go ahead and deliver. Okay, so that is the definition of a reactive non-stress test. Okay, so here we're going to look at a strip. This is what a fetal monitoring strip looks like. So 150, 160, 170, 180. So these are 10 beats in between each one. Sometimes it's 5 depending on what you're looking at. These red lines are minutes. So 1 minute, 2 minute, 3 minute, 4 minute, 5 minute, 6 minute, 7 minute, 8 minute. If I want to first determine the fetal heart rate, I have to look between contractions. So if I look between the contractions and I drew a line like this, just a line through it, I would say the fetal heart rate's about 145 to 150, right? You got to look in between contractions. Yeah, about 145. Okay, so 145 to 150. So it needs to hit 160 twice and last 15 seconds in 20 minutes. Well, this is a 1, 2, 3, 4, 5, 6, 7, 8. This is an 8-minute strip. You have to always leave a patient on for at least 20 minutes just to be considered a non-stress test. But look at this baby's already reactive because 180 and each box is 10 seconds. So look, that's more than 15 seconds that was up there, definitely. 10, that's about 20 seconds and it reaches 170. So I'm good. So this baby's reactive. And do I see moderate variability? Yeah, I do. If I look in a minute, it goes from 150 down to 130. Yeah, I definitely have between 6 and 25. Okay, so this is good. And no, just this is maybe like a little mini variable when I talk about decelerations, but nothing else. This blue is 110 to 160, right? Remember we talk about what a normal fetal heart rate is? It's great if it goes above it, if it comes back down. That's not what's concerning. It's sustained above or sustained below. What will happen is you see, like, if you turn it, if you were to turn it the other way and draw a line through the middle, that's how you can often find the fetal heart rate. Is you just go, you'll see nurses flip the paper a lot and look down, and that's kind of how, if you were to draw a line, if this baby were to become tachycardic, you'd see it go like this. And then what would happen is you'd see it start to go up and go like that, and then you'd see it start to go up and stay like that, okay? And you'll see it rise, start to rise. So now this is the ultrasound. This mom is on an external monitor. How do I know that? Because it says external, okay? And TOCO. We know TOCO means external. TOCO looks at contractions, and external is the fetal heart rate. So TOCO is external versus an IUPC. If it was internal, it would say IUPC and FSE, fetal scalp electrode. So this mom, we time contractions from the beginning of one to the beginning of the next. Okay, so this mom is contracting 1, 2, 3 minutes. Okay, and 1, 2. So every 2 to 3 minutes. You're rounding. It's not like you're going each box. So every 2 to 3 minutes, how long are they lasting? Well, let's see. The shortest one is lasting 10, 20, 30, 40, 50, 60. From when it starts to go up and comes down is 60 seconds. Each box is 10 seconds. And when it starts to go up, I would say 10, 20, 30, 40, 50, like 60 to 110. That's how long they're lasting. Great. Okay. So each red line, minute, each box is 10 seconds. Each box this way is 10 beats. Okay. So this is a nice reactive. Now let's say she was in labor. Let's say she's just in labor because this is in the doctor's office. She's contracting every 2 to 3 minutes. Often in the doctor's office, you're not seeing any contractions. We might say, let's keep her on longer and see if this is going to peter out. Let's give her some water. Let's see what happens over the next 15-20 minutes. Is she feeling them? Is she uncomfortable? Is she dilated? Maybe the doctor will do a vaginal exam after an hour and see, is she changing, or is this just her normal pattern? This would kind of be a lot. So that's sort of the other information you're going to get. So you might be doing non-stress tests on people at risk for preterm labor. They have a history of preterm labor to see, are they having any contractions? So you're always going to look at the baby because that's important, but sometimes you're doing a non-stress test to see if their uterus is active and what's going on. This is most likely in labor because of the contraction pattern. So we're now going to talk about decelerations. So fetal accelerations and decelerations can all be remembered in what we call veal chop. You will need to memorize this slide. You will need to know this for Hesse and NCLEX. If you write the words veal and then chop, you have variable deceleration, early deceleration, acceleration, and late deceleration. You will need to know all of these. I'm going to go over each of them with you. We already went over acceleration. It's okay, so it matches the O. It's good, really. It's great. It's reassuring. Variable deceleration is caused by cord compression. Early deceleration is caused by head compression. Late deceleration is caused by placental insufficiency. Which one of these do you think might be the most ominous? The answer really could be either. If it's cord compression because the cord is fallen out of the mom, that is so bad you got to rush back to a C-section. Remember, if you find it, it's yours, ride the cart. If it's just because the baby's laying on the cord and you flip the mom, then it's okay. What you need to know and take away from this slide is not just memorizing what it means, but thinking about as a nurse what it means you should do, because that's how they're going to ask you questions. So if you have a mom who's having variable decelerations, your first nursing intervention is going to be positional change. Flip that mom over. If you have a mom having early decelerations, you don't need to do anything. That's head compression. That baby is coming on down. That's good. You might, as a nurse, check her to see if mom's getting close to delivery or close to time to start pushing, but there's nothing you need to do, and I'll show you what these look like. Acceleration, nothing you need to do. Late decelerations can be placental insufficiency. These are not good. 1 or 2 or 3 random lates is okay. Again, maybe the mom has a little hypotension caused by an epidural and you need to just up her IV fluids. Maybe for whatever reason, the mom is laying flat and was on her side, went to her flat back, and now her gravid abdomen is putting pressure on those major arteries and blood vessels and causing placental insufficiency. So you just put mom in left lateral because that's what's going to drain it and open it up the most. And maybe that's all you need. If you have repetitive lates, you will always see late decelerations in the presence of absence variability. They go hand in hand because that baby is stressed out. So think about that. If you have absence variability or minimal or absent, that baby's getting stressed out. So, just a sleep cycle? Oh, wait, I'm having lates. Ooh, I'm having lates with every contraction. So not only does this baby, it's not a sleep cycle because this baby, every contraction is having a late. This baby is stressed because we know when you have a contraction and you cause that baby to hold their breath, they need those reserves, and this baby is stressed and is showing these little decelerations. And so repetitive lates, not good. Repetitive lates and minimal variability or absent variability is going to buy you a ticket to the OR. It's not good. Okay, but often those babies do okay. We just know labor is stressing them out. We got to get those babies delivered because labor is stressing them out. So early head compression. I'm not even going to go why it happens. It has to do with the baroreceptors and things like that. But it mimics the contraction. If the acceleration is doing this, the contraction is doing that. So I'm going to show you a picture. Look, it mimics. The peak of the contraction is at the peak of the deceleration. Now this is minimal variability, which is okay. We're only looking at 1, 2, 3, 4, 5, 6, 8 minutes here. So we can't really determine it. Definitely earlies though, because it matches the contraction, okay? They're not real deep. Deep decelerations are always variables. Earlies and lates are very subtle. Okay, sometimes earlies can be a little bit bigger, but the variables are like variable, and you'll see they're like variable and really like up and down and craggy and ragged and all those kinds of things. So the head is just getting squeezed. Okay, that's good. Nothing you need to do. Let's see how long this mom is contracting. She is contracting. Okay, so 1 minute is here. So it starts a couple before. So I just kind of go whoop. I'm just used to looking at it that I can just guess 6 over. So about 1.5 minutes there, a little less than that. She's contracting like every 1.5 minutes. So I'd want to see that's a lot. If she was on Pitocin, I might kick it down a little, but they're only lasting 20, 10, 20, 30, 40, 50. So here's the thing. Can the baby hold their breath? Can the baby catch their breath in between? Yeah, probably 10, 20, 30, 40, 50, 60. You're going to want to watch that. So again, this is why when someone's in labor, you're watching this the whole time. These are all the little nuances you start to learn. Again, you don't need to know that. I'm just trying to show you as a labor and delivery nurse what you might look at. Late. Does anyone like to be late? No. Do teachers like when you're late? No. Are lates good? No. Does anyone like when they're early? Yes. Do teachers like when you're early? Yes. Are early decelerations okay? Yes. That will help you remember. Late decelerations are a sign of uteroplacental insufficiency in oxygen. Now, this looks very similar to the other one. Now, she's not contracting a lot, really, at all. She's 1 minute, 2 minutes, 3 minutes, 4 minutes there, and then we're already at 1, 2, 3, 4, almost 5 minutes. So every 4 to 5 minutes, that's good. Let's say if she's already stressed every 4 to 5, could you imagine if this mom was every 2 to 3? I would not be going up on this mom's Pitocin if she was on Pitocin. If anything, I'd probably be turning it off because this baby's stressed. Because if it's an external monitor, we have no idea. These could be super strong contractions, but on an external monitor, it's just based on where you place it, how much it kind of shows. So how do we know it's late? Because that dip right there is after the peak of the contraction. The dip is after the peak. So they look, and we have minimal variability. Minimal variability. They look very much like earlies, but the difference is the dip is after. Late is bad, early is good. It means you're coming out, baby's coming out, early is good. Variables. Variables happen all the time. They're variable. They have no pattern to it. Lates and earlies mimic or are after contractions. Variables just occur. They come, they start quickly, they go up quickly. They're called, oh gosh, my phone is ringing. They're non-periodic, which is different than periodic. Earlies and lates are periodic. They periodically occur with contractions. Variables are non-periodic. They require nursing intervention, but they don't require necessarily rushing back. Oh God, this patient. Well, either this patient's going to deliver or they're going back to a C-section because those are some big old variables, okay? Now, if a variable is occurring after contraction, it's still not considered late. It's a variable. The lates are subtle. They're little dips, and the earlies match it exactly. I can tell this mom is pushing by looking at this fetal monitoring strip because I can look in this. Do you see how it's jagged like that? She's either throwing up or pushing because her abdomen is going in and out. So she's pushing because it's 3 contractions in a row here. It looks like they gave her a little break here from pushing because look what happens when she pushes. Every time she pushes, boom, that heartbeat goes down. Boom, that heartbeat goes down. Boom, that heartbeat goes down. But look, it went down, and it went down low. I think that's 60. It went down low, but hey, it recovered. They had her not push for 2 contractions. You see, she was contracting every minute, which might be why this is happening. We know the cord is being compressed, and if she's contracting this often, that baby's not getting able to catch their breath. So sometimes as a labor and delivery nurse, she'll say, now you're calling the doctor when this is happening because a baby has reserves for so long, and I'll show you how you can see that it's changing. Again, this is way more advanced than what you would need to know. All you need to know is, boom, these are variables. Because look, this baby does okay. The heartbeat comes back up and does okay. Look at this one. The heartbeat comes back up, but then mom pushes again and it goes back down. Do we think that baby could catch their breath? Yeah, here the baby caught their breath. Here, no. This mom needs to deliver, and I bet because she's pushing, she was probably close. This happens all the time at the end of labor, all the time. That cord gets low, the baby gets low, there's a lot of pressure on the cord. As long as that baby's going to deliver soon, you're fine. But you may anticipate this baby needs a little jump start after delivery. I'd probably be calling the NICU to come just in case. And if this doesn't get better, that mom's having a C-section. That's kind of that's a yucky strip. This is more often how you're going to see variables, okay? Don't worry that they come after the contraction. It has nothing to do with it. You're going to see lates with minimal variability, okay? Because variables often happen with good variability, and you'll see the cord is just being compressed, but totally recovers after cord being compressed. So you might flip the mom. You might try to see what's going on. Look at these beautiful contractions. I have a feeling she has an IUPC in because it's so straight like that. She may have an IUPC in. But you can see 1 minute. This is really easy to read. So timing of the first contraction to timing of the next. So 1 minute, 2 minutes, and 30 seconds. So like 2, 2, 1, 2. Like every 2 minutes, this mom is contracting. And how long are they lasting? 10, 20, 30, 40, 50, 60, 70. And then we go to the longest one, 10, 20, 30, 40, 50, 60, 70. It's like 70 to 100 seconds. So that's how I would chart it as a nurse. And again, made another nurse say 90 seconds. Yeah, I mean, it's a little gray in how you interpret it. Now, see, this one goes to here and this one goes to here. If there's an IUPC in, you actually look at, you can tell how strong it is, and that's a whole thing to go into. I'm not going to go into, but if it's an external, it doesn't mean anything. It's just where it is. But the fact that it almost looks like someone took a marker makes me think that there's an IUPC in this patient. But these are your very typical variables. Go back up, good variability, the heartbeat's not dropping, versus these variables where like, ooh, the baby's having a hard time recovering. You can see it happening. So you gotta let the baby catch their breath. So what are your nursing interventions? That is your takeaway. Your nursing intervention for a late, remember, you're gonna see minimal variability. You're gonna see these dips after the contraction. You gotta figure out, why is there placental insufficiency? What do you need to do to fix that? IV fluids, put mom on their side, stop the Pitocin, check her blood pressure, all those kinds of things. Reassuring, this looks great, no decelerations whatsoever. So this is mild variables, no problem. Severe, it's getting worse. This mom, again, she's pushing. You can see this mom's pushing too, but the baby's doing okay. This is not pushing, this is pushing. Can you see the difference? Just FYI, kind of interesting. It gives you a little better picture of what's happening. So again, I just went over this. What are you looking at with the uterine activity? One of the things you always want to make sure, and that's why I said hands-on mom, because if a mom is abrupting and you feel her belly and it's in between contractions and it's still firm, that is not resting. There's not a resting tone. You need to be able to chart every shift that in between contractions, that abdomen was soft to palpation. If you guys run the slideshow and go to this fetal heart rate tracing game, you can actually do some practicing. This is a really cool website. It's not the same one you're doing for clinical tomorrow, but it's a really cool website. So this is just a review of what I've talked about. Why do we do fetal surveillance? For a couple things. Antepartumly and prenatally, we do it as a non-stress test. Intrapartumly and during labor, we do it as continuous fetal monitoring. It's only during then that you might see an FSC or an IUPC, and you do that for non-reassuring fetal heart rate, or if you're unable to monitor the contractions. That's a fetal scalp electrode, intrauterine pressure catheter. What do you do if you still have like a really sleepy, what looks like a sleepy baby or absent variability? Your next step, they can do some fetal scalp. Babies, when you put your fingers in and scratch their scalp, you should see an acceleration, just like my heart rate would go up if you out of nowhere went and scratched my scalp. So that can be a sign. If you're not having positive fetal scalp stim, you may have to go ahead to a C-section. Antepartumly and prenatally, what do? We do a non-stress test. We talked about all the reasons why people have a non-stress test. Most people will just get a Doppler for fetal heart tones. However, if you're in a special subset, you may end up with a non-stress test. If it's reactive, great. Redo it in a couple days. If it's non-reactive and it's been 40 minutes, the nurse can use a vibroacoustic stimulator and it goes zzz, and you put it on the belly and it just makes a loud noise, because some babies will jump with that. If they respond to that, that's a good sign. That is considered a true acceleration. If they don't respond to vibroacoustic stim, you're like, we have a reactive, repeat in 3 to 7 days. We have a non-reactive. Do you remember what reactive is? 2 accelerations in 20 minutes, 15 beats above the baseline, lasting 15 seconds. 2 accelerations, lasting 15 seconds, 15 beats above baseline in 20 minutes. You need to know that's what a reactive non-stress test is. This is what is done prenatally, antenatally to check for fetal well-being. If it's non-reactive, they may send you to the hospital for continuous fetal monitoring, or they will most often send you to an ultrasound where they do what's called a biophysical profile. And based on that score, they may say, let's watch you for a couple days on continuous fetal monitoring and see what your baby is doing. We may be moving towards delivery, but again, cook or deliver, cook or deliver. So a biophysical profile looks at 5 different components. The first is the non-stress test. Well, guess what? If you didn't have the 2 accelerations lasting 15 beats, at least 15 seconds, you got a 0 on that. So most moms already are going to, if they've set for a BPP, they already have a 0 on this. So the highest you're going to get is an 8. So an ultrasound looks at the fetal movements, looks at the fetal tone, looks at fetal breathing, and looks at the amniotic fluid volume. And based on this number, they can decide if you get an 8 out of 8, that's reassuring. Okay, if it's 6 out of 8, the doctor may admit you to the hospital. If it's 4 out of 8, you may be moving towards delivery. Not necessarily a crash C-section, but looking at what's going on. So you need to know what a biophysical profile is. This is an ultrasound in combination with a non-reactive non-stress test, basically. And it's sort of the next level if you have a non-reactive non-stress test. So what are non-reassuring patterns? We talked about this. Absent variability that doesn't get better. It's not like the baby's just sleeping, where you have recurrent late decelerations or recurrent variables. Even though we said variables are okay, remember in that one slide, you could see how the baby lost the ability to catch their breath, and now it's getting bad. Or bradycardia. Bradycardia is never good. So it goes down and stays down. You're rushing back to a C-section. Sinusodal is when, it's pretty rare, and sinusodal is when it looks like someone took a pen and just went up and down, and it's undulating, and it's like the same pattern, up and down and up and down and up and down and up and down and up and down, and there's no variation in it whatsoever. And it's often a sign of fetal anemia. It's very rare to see that, but you'll see that in an abruption sometimes because of the blood loss. So it's a C-section if you have that. So this is just a picture of fetal scalp electrode, tickle, 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 and that heart rate better go up. So that's what you see in continuous fetal monitoring. So what do we do for non-reassuring patterns? Remember, when you are learning, I need you guys to always be thinking about, as a nurse, what you do. You're not going to do a C-section, right? So you need to look at the cause of the pattern. Is it hypotension? Is it positional? Is there too many contractions and it's hyperstimulation and this baby can't catch their breath? So what might you do? Increase placental perfusion. Place that mom on left lateral. Increase her IV fluids. If we're worried about the baby having hypoxia and being acidotic, because that's what we're always looking at. This is why we draw blood gases from the cord once a baby's born, because for legal lawsuits, they want to be able to show, was the baby acidotic at delivery or not? Hopefully not. But how can we increase maternal blood oxygen? We're going to slap a mask on that mom at 10 liters per face mask. Every laboring mom has an O2 mask ready to go. And it's always 10 liters per face mask because you're maximizing the mom's oxygenation regardless of what her pulse ox is. And then reduce cord compression if it's a variable, right? Change that position. See what's going on. If it's a really deep variable and all of a sudden it dropped down and stayed down, I might be looking between her legs to see if there's a cord hanging out her vagina. Then I need to now go push that head up, get her on hands and knees, and ride my cart to the OR. Okay, so you got to think about, why are these things happening? You must know uterine resuscitation. That is what we call this. You need to memorize these actions. These are the things you're trying to do. Decrease the UCs, that's uterine contractions. Decrease UCs because a baby can't catch their breath. Turn off the oxytocin, that's Pitocin. Sometimes we give terbutaline, that's a tocolytic. Sometimes that will relax the uterus. Turb is one of those things, a little try. It's a little, research doesn't always support it, but they'll go ahead and have you do it. I'm getting another phone call. Increase the IV fluids. Get more fluids in mom. Maybe she's hypotensive. Get that O2 going at 10 liters per face max. Change her position. Try to get her off that vena cava, right? Going down, trying to get her off of that, and instead get her on the left side. Vaginal exam. Is that cord hanging out? What the heck happened? Scalp sim. Tickle, tickle, tickle. Can we get that baby to react? That's a reassuring sign. So the last slide is just something, if you think about it, it will make sense. But I need you guys not to just memorize. You guys need to think about why we do these different things. What affects the placenta and the uterine blood flow, right? What affects the oxygen in the mom, blood pressure, underlying conditions, and then what affects the baby, right? How do we maximize umbilical blood flow? We have to get the baby off the cord in a different position. So we have to think about, is it uteroplacental insufficiency? Is it because the mom has lots of calcifications and an old placenta? Or is it because the baby's in a weird position? Or does the baby have a cardiac anomaly? You may not know all these things, but you just need to think about why we're doing what we're doing. So there you go, fetal heart rate monitoring in a nutshell.